Good morning, afternoon, and evening to everybody who's joining us in the webinar today. Welcome to Bridging the Cancer Research Gap, Connect and Collaborate. This webinar is brought to you by the Global Cancer Research Knowledge Hub and the Global Health Network in the University of Oxford. My name is Mohammad Abdalmohsen. I'm a respiratory physician and special interest lung cancer. And I'm from the Global Health Network. I'll be chairing the event today along with my esteemed colleague Farah Rasheed from Shaukat Khanum Memorial Cancer Hospital. First, I will be starting with a bit of housekeeping. So before we begin, the first thing, this session is being recorded, and the recording will be shared in the coming few weeks on the Global Health Network platform. So you can review, share the materials, and these materials can be found using the link that's just being shared in the chat. Please use the chat feature for introductions. We would like everybody to one of the aim of this session is to connect and get people to be introduced to each other. So please use the chat function to introduce yourself and raise any technical issues that you might be experiencing. The Global Health Network team will assist you with these. To interact with our panel today, please use the Q&A feature to post your questions and comments, and you may also do that anonymously. Due to the number of participants, your video and microphone has been disabled. There may be an opportunity at the end of the session to ask questions. Please raise your hand and we will enable your microphone. After the sessions, we have dedicated a time allocated for Q&As, and we will try to get through as many questions as possible. If we don't have time for all your questions, we will compile and address them after the session. We will now begin the program for today, and I would like to introduce our topic. So this is the registered today for the webinar. So thank you everybody for joining us today. And next slide, please. So we have got the program today, and basically the Global Health Network is introducing the Cancer Research Knowledge Hub to accelerate cancer research and strengthen clinical service, expand training and policy, particularly in low and middle income countries. The Global Health Network is internationally recognized for advancing equitable research through capacity building, open knowledge sharing, and global research and collaboration, especially in low resource setting. Our event today will have multiple esteemed speakers from around the world. We have got Professor Trudie from the Professor of Global Health and the head of the Global Health Network, Adam Dale, the Knowledge Exchange Lead from the Global Health Network, Dr. Yolanda Augustin from the International Affordable Diagnostics and Therapeutics Alliance, Malaysia, Professor Bola, Afolabi, Balogun, Molecular Biology and Genetic Diversity Research Laboratory, and from the Fountain University of Sogobo, Nigeria, and Mark Lodge, the head of the UK and Ireland Global Cancer Network. So we will be, without any further ado, we'll be starting with the presentation from Professor Trudie, and if I may introduce Trudie. So Professor Trudie is a professor of global health research, and she is the head of the Global Health Network and a senior research scientist in tropical medicine at the Nuffel Department of Medicine. She has over 20 years experience in running clinical trials, including trials in the developing world, low middle income countries, and for pharmaceutical industry, the World Health Organization, and in academia. Dr. Bland focuses on combating disease of poverty through generation of high quality evidence, and with her team and partners, she works to drive better health outcomes in vulnerable communities by enabling local leadership and ground-up implementation of high-quality health research and studies. Within the University of Oxford, she devised and leads the Global Health Network, which is a major international collaborative enterprise and sets out to improve health by improving research. So without further ado, I leave you, Trudie.
Thank you, Mohammed, and welcome everybody. Good morning, good afternoon. It's always great when we run these webinars to just see the diversity of people from across the globe, and appreciating the very late evening it is for some, and nicely in the middle of the day for others, and of course any Latin American colleagues, it's very early. Just to my panel supporting us, could you run the slides, please? Because Zoom isn't playing with my laptop today. So could you just run the slides and we'll move through them. So as Mohammed kindly explained, I'm just going to take you through what we've been doing with the Global Health Network over the last 10 or 15 years and try and orientate this to what we really hope today is a starting point. It involves everybody. I mean, it's really great to see we've got over 100 people already on the call, and I hope all of you see this as something that you're part of from this very second. And this is the whole emphasis of the Global Health Network, is a mechanism to connect us all together and to see how we can accelerate progress by connecting and convening. And that, you will hear, is going to be the whole theme of today's session. And so particularly we want to focus and see if we can build on what we've learned on how to bring people together and really apply that in the terrible burden that cancer is causing across the globe, and just change the inequity in where research happens at the moment. So next slide, please. So next slide, thank you. So what a lot of this is around is how most research in the world happens in very few places, and it's led by even few people, and the benefits of that research is not felt fairly across the world, and we know this. And so one of the things that we can really look at is who is it that's leading that research, where is the research thought about and created, and who is it impacting most. And so really what the Global Health Network is trying to do is shake up some of those old hierarchies and norms around data being extracted elsewhere, for example. Who can think of themselves as a researcher? We believe everybody could be a researcher, even from the patients to the community, right through the whole healthcare system. And that's really what I'm going to talk you through today. So next slide, please. So what this has become over the years is a facility that happens online, and I'm hoping you've all visited the Global Health Network, which is why you're here today, or you've at least heard about it, but also something that happens in person, and I'll talk more about those mechanisms in a minute. And it came about as a really basic early starting point, that the things that hold researchers back, or hold healthcare workers back from being researchers, really doesn't change. It doesn't matter what disease you're working on. It's really about the situation you're in and the access to tools and resources and training, and really importantly, support to do research. And so what we set out to do many years ago in East Africa was to say, well, it's just, there really isn't parity really on what diseases are benefiting from research and who is leading those efforts. And so this began as a really basic premise to say, well, let's get people who are working on malaria, HIV, TB, maternal health to share more in one place, so that we can spread it out. Because certainly when I was working 30 years ago in Africa on malaria vaccines, I could walk into a ward next door from the pediatric ward, maybe orthopedics or anywhere really, and they'd never know what research was and never be able to do research. And so it was all around how can we share out those skills between different disease and therapy areas, and so everybody can become upskilled and become researchers. So what we have now is this genuinely a community, and that's what I mean by welcoming you all, and that this is your community. And the idea is that this is simply a mechanism to move knowledge like osmosis between you. And we can do that online through the Cancer Hub we're going to talk about today. And we can do that in person as well by people being champions for this in their regions and going to do research clubs and talk to people. And we've got a whole ways of doing that, which is what we'll share through the Global Health Network. And so this is a mechanism of creating different topic areas, such as we're doing for cancer, and then having that delivered alongside those cross-cutting skills that you need. So next slide, please. So what we definitely know is that it doesn't matter what disease you're working on, and it doesn't matter where you are, that the barriers to becoming research leaders don't change. And so we've done lots of research over the years. This is a pooled analysis of about 7,000 participants. When you ask them, what is the barrier from you running your own research studies, they'll say access to research skills and training, and that's an easy one to solve, and that's what we're very much all about. But the second one is access to support, which really means the mandate for research. And so that's about working and thinking in healthcare settings. If you want to do some really straightforward research on how cancer care is accessed, maybe, or new use of existing therapies, or anything you're going to hear about today, who needs to give you the mandate to do that research? And it isn't always expensive as well, and we'll come back to that later. And so these cross-cutting skills we can give, and we can change some of these cross-cutting focuses. But what this can all benefit from is coming together with a focus on cancer and seeing how we can really leverage these gaps and have everybody working together more closely and getting more research underway. Next slide, please. So if we think about any disease, we need the full ecosystem of health research. And so you can literally apply this to anything. So for any disease, be it a non-communicable disease or an infection, something that's been around for as long as mankind, or an emerging new outbreak, we need to understand the burden and the epidemiology. We need to understand behaviors and treatment seeking. Of course, we need diagnostics, and then we need therapies and we need to evaluate those through clinical trials. We need health economics, we need laboratory works, and so on. But the really good news is that for all of those different types of research, we can bucket any research up into a cycle, and it comes down to the same things: setting a good question, measuring the right thing to tackle that question, working with the community to make sure that question is the right question being asked in the right place on the right people and being measured in the right way. Really good data science, I'm going to come back to, and thinking all the time about, when I get the results from my study, how am I going to use it? How will those be taken up to really make a change, whatever cycle it is and type of research. So this diagram is really the premise of what the Global Health Network is all about. And underneath it all, we try and use these basic points that we need a whole ecosystem of research to tackle any disease, and that for any type of research, the practitioners doing that research need the same sorts of skills, obviously adapted for this particular context. So what I'm challenging you all with today is, can you think about this in the context of cancer research and all the different types of research? And I would love to know from you all on the call what type of research you're doing and where it falls into that cycle, and also potentially the gaps you have in how to design and run and get going really good studies. And so this is what we try and adapt to every different context, and then try and build this community of practice. So next slide, please. So this all began about 15 years ago, as I said, in Africa, trying to share the areas of really strong research experience to none. And so now what we have is this partnership with organizations across 60 different countries, which means people on the ground who are these sort of ambassadors for this whole concept of sharing research knowledge. And we have over 1 million members, which I hope includes all of you, who come and find these tools and resources to do their research. And so this is a really exciting basis, isn't it? Where if we're going to try and bring together a cancer community within this, we've got this really excellent starting point. Another thing to say is that we're also a WHO collaborating centre for research in their science division, and we're a collaborating centre for knowledge sharing and capacity building. So obviously that's exactly what I've been talking about. So that's a really wonderful thing we can all leverage, as being a WHO collaborating centre, and have that confidence that we're working very much hand in hand with WHO and that there's this recognition that we all need to work more closely together in these networks and share what we can do to do more in generating the evidence we need. Next slide, please. So if you go into the Global Health Network platform, you can see it's these two elements that come together. We've got over 60 different partners, which are organizations who use the Global Health Network to share their knowledge. So this varies from Fiocruz in Brazil, AMREF in Africa. There's a whole raft that are either working on particular topics like community engagement or epidemiology, or they're working in a region, or they're working around a particular type of research. And so what we're really talking about today, and this is what Adam will explain more, is within this science park, I often call it, or like Netflix or Spotify, this is a digital facility where we can organize and curate information into different topics, and then people can find it because it's within it's bucketed up within that particular topic. And so what we're going to add to this from today is this cancer area to help this come together and coalesce so we can share the information on cancer. And then the other side of it is we have the training tools and resources and the activities in the region. And so we try and connect and cross over as much as we can. So across regions, across topics, and then across types of research, as you saw in that diagram, and also the skill sets that you need, such as data science or community engagement or health economics, whatever it might be. So we just try and curate and cross-link as much as we possibly can. And Adam will talk about that more in a second. Next slide, please. And then this is where the magic happens, really. And I really hope all of you might be interested in helping with this bit, is really making it happen on the ground. And my favorite approach in all of this is the simple concept called a research club. And this is where any hospital, any clinic, any healthcare facility can set up their own research club. And I often think, most places often have journal clubs, and that's great, but that's learning about somebody else's research at the top of that pyramid. And it seems distant and far and not something I can do, most people tell me. But if you set up a research club, it kind of flips that pyramid up and just have a space once a month, once a week in a healthcare facility and say, let's all get together and talk about our research. And we'll provide you resources to do that and give you some tools and support. And we would really like to hear about them. And so that's one thing I would definitely challenge you all to do. Anybody's interested in setting up a Global Health Network Research Club, please give us a shout, because it's just such a great way to get this stuff. And of course, you can focus it on cancer, and we can give you all the tools and resources. And then beyond those, there's all sorts of things to access, from specialized topic clinics, say on data science or community engagement. We can run supported learning sessions where you can get somebody in online to teach. Often for the online learning that's available, it's really great to do that as a group. So that's also a good way to do it. Next slide, please. So just finishing off, I just want to mention briefly data sovereignty and the opportunity to analyze existing data. People often think that health research is a complex clinical trial or genomics in a lab, but just analyzing the data you already hold is a brilliant place to start. And we've got lots of tools and support to help people analyze existing data set. And I think there's so much potential in cancer care, about even beginning by evaluating epidemiology, burdens, and even treatment access pathways. There's probably the data there already, and it's just about having some help in analyzing it. And that's where we can give support as well. Next slide, please. And in terms of operating in the regions, we're making new transition this year and setting up a unit within the UN so that the Global Health Network coordinators across the globe will be employed through a UN entity. And that just really helps us shift beyond this being an Oxford-led project to being a UN entity, and really helps with this mutual connecting and convening. Next slide. Perfect. And so just to finish off, really, I hope I've challenged you all to thinking about how you might get involved. I'm really excited to listen to my colleagues that we've been talking for many years about having a focus on cancer. So I'm so delighted to see this come together today. Please get involved in the networking session at the end, and please stay in touch after today. So thank you, everybody. Congratulations to my colleagues for getting this far. And I'm so excited to see how you can all take this. So I mean, all 139 of you on the call. And looking forward to joining in the discussions at the end, hopefully.
Thank you very much, Trudie, for the amazing talk, and very inspirational. And I'm sure Many questions will be coming over, and we'll be using the Q&A session at the end for that. For the next speaker, I would like to introduce my colleague, Adam Dale. Adam supports the Global Health Network, and he is the lead for the Building the Knowledge Hub. And he will give us a talk running through an introduction to the Cancer Hub. So off to you, Adam.
Thanks, Trudie, for outlining what the Global Health Network is. If you're not a member, go to tjshan.org and sign up. And we've just soft launched this Global Cancer Hub, which is a repository for some of the resources and shared knowledge as part of this, the kind of broader cancer research knowledge hub, which is very much made up of you, everyone who wants to get involved. And what we're doing with this hub, sometimes we'll launch with a huge amount of resources, material already. What we really want to do here is make sure that from the ground and from the start, it's shaped by you, the experts, and very much from sort of a global perspective. And we can see that already from all of the people who registered and all the people who are attending today's session, how global we are and how diverse the experience and the range of disciplines, all around centered around an interest in cancer research. I'm hoping that this very, very brief presentation from me will address some of the questions we had in registration, a lot of which were around how can we collaborate. Well, here we are. I've put in the link to everybody, a link to the Cancer Hub, and you'll see there that really just from the start, there are two key areas we want to start off with in order to help shape what this hub will be for. And we're hoping that from the feedback we have from you, we'll have a sense of articles that need sharing, resources, tools, those kinds of tools which could be useful globally, where they might need to be in a regionally contextualized, the challenges, the good examples of innovations, all sorts of things which come across. And what we're able to do is link people up together, not just have a space where you just access resources, but also, as Trudie was saying, it's really going to be a community of practice, particularly around cancer research, where we can really link people up. And the ways we're going to be doing this are twofold, really. You've got a QR code there in the corner, but we'll be showing this in the chat. We can share a link and also at the end as well. We've co-created a survey, and all of the speakers who we're going to listen to in a few minutes have been involved in this as well, in creating a fairly extensive survey which is asking all kinds of questions around what would you like to see on our hub, where are your challenges, questions which might be specific to clinical practice and others which are much broader. It's a survey which takes around about 10 minutes. You can skip any questions which aren't relevant to you, so it can be as detailed as you'd like it to be. But it's really going to help form an idea of what we should have on the hub beyond the sort of small amount of materials that we have at the moment. So don't go off and start filling that in now, because we're going to hear some brilliant presentations. But save that for now, that QR code, and we'll do it afterwards. We're going to be sharing the code later on, and please do share it with anybody you think it's going to be relevant for. We're going to be keeping it open, and this is particularly for the webinar recording of this. We'll be ending it around about end of March 2026, so it shouldn't be accessible after that. And after that, we'll analyze it a little, and it'll really help shape what this hub should be. For instance, articles, resources, toolkits, e-learning, training, which already exists across the platform on the Global Health Network. We can link back to the Cancer Research Hub, but we're hoping we're going to get a lot of information from you to help us shape this. The second thing we're doing, and it's worked really effectively across a number of other of our knowledge hubs, is this connect and collaborate. So we have a map there with a sad little single purple dot, but we're hoping that, well, once again, we'll share the link to this. Once you add yourself onto this map, and the survey is an opportunity to do that as well, we're going to start seeing people from all over, and we'll get a sense of who you are, what you're doing, what you're interested in, and we're going to be able to actually help link you up together. And we can help in terms of identifying knowledge clusters, from a geographic perspective, or maybe from a particular interest, and link you up with collaborative meetings. We can help, as Trudie was saying, we're getting feedback as well. If you're running research clubs, we can get a real sense of kind of the impact of working together. So those are the two key areas which we're starting this Cancer Research Hub with. So we're very much in the infancy of it, but you're there right from the outset. It's brilliant you're here. Please share those links with everyone else. Please fill yourself your details in on the map and complete the survey as well, which is just a simple Google form like this. And then within a few months, we'll start seeing this evolve, and we'll have some activities which will really help link people up together based on the information we're getting from you. So I'll stop there and we'll get on to the real good stuff, which is the presentations from all of our speakers. Thank you very much.
Thank you very much, Adam, for running us through the hub and mentioning the survey. Our next speaker is Dr. Yolanda Augustin. Dr. Yolanda Augustin is a Malaysian oncologist, and she specializes in sarcoma and in global oncology. She trained at Guy's and King's and St. Thomas School of Medicine, and she completed the clinical training from the Royal Marsden Hospital in the UK. And within also the global health oncology experience, she's affiliated with the International Affordable Diagnostics and Therapeutics Alliance to support equitable access to cancer care across Southeast Asia and the Global South. And we'll be hearing more from Yolanda. So the microphone with you.
No, thank you so much, Dr. Mohammad. So it's a great pleasure to be here today, and I'll be speaking about the International Affordable Diagnostics and Therapeutics Alliance, and how we basically are developing locally led affordable innovation to try and make healthcare access and also research more equitable, particularly for cancer in the Global South. So why is this so important? Well, we know that cancer incidence and mortality continues to rise, and it's rising fastest in low and middle income countries. Yet timely access to diagnostics and effective treatment remain profoundly unequal. Many healthcare systems across ASEAN and the Global South face the challenge of late presentation, limited access to pathology services and imaging, and also out-of-pocket costs that push families into poverty when they seek cancer care. And on World Cancer Day, as we talk about closing the gap, we need to move from importing high-cost technologies to co-creating solutions that are designed for our epidemiology and our healthcare systems in the Global South. So the International Affordable Diagnostics and Therapeutics Alliance believes that basically bridging the oncology divide and ensuring that we see healthcare as a human right is pivotal to achieving these aims. So this is a picture of an area in Balogun in Sarawak, which is part of East Malaysia. And essentially, this is where we have been doing some of our cancer outreach in the past few years. And this is a longhouse where basically the indigenous community from the Orang Ulu community live. And it takes them about 4 or 5 hours to reach their nearest hospital. And embarking on cancer screening and also cancer treatment is very challenging. Many of the patients that live in this area, when they're diagnosed with cancer, will actually be diagnosed at a late stage as a result of those logistical challenges. And when they are diagnosed, then they actually have to travel about 8 hours to Kuching, which is the center of Sarawak, which is over 500 miles away. And there they basically will have to stay to actually undergo their treatment, which comes with a lot of difficulty in terms of out-of-pocket expenses and burden on their family. So in the IA Data Alliance, our focus very much is on how we can reach and empower local communities in low-resource settings, because we know that this is actually not an isolated story. This is also a common experience that is shared by many other countries within Southeast Asia, but also many countries within the Global South and Africa. So in Malaysia, over the last 10 years, what we have been focusing on through the Ministry of Health and also the Ministry of Higher Education is basically building on the research infrastructure and ecosystem. And Malaysia is strategically positioned within Southeast Asia centrally. We have actually very well-trained workforce in terms of doctors, nurses, pharmacists, physiotherapists, and allied health professionals. And we have been encouraging the rollout of basically research centers. So there are now 37 research centers under the Ministry of Health in Malaysia. And allied health professionals, as well as nurses and doctors and trainees, are encouraged to get involved in research through these research hubs. And over the last 10 years, we're proud to say that we have managed to bring in more than 2,500 clinical trials to Malaysia. And oncology is actually the highest portfolio in terms of clinical trials. But to date, this has been mostly pharma-led studies. And so whilst we see that as a huge step in terms of capacity building, and also it has brought in revenue for our countries, it's generated about 1 billion in revenue, 1 billion ringgit through the work of Clinical Research Malaysia that has worked very hard on this. We now also want to look at developing more investigator-led studies and also more homegrown studies in Malaysia for diagnostics and also for therapeutics. So part of Malaysia's new Industrial Master Plan 2030 at the policy level is also to focus on manufacturing for diagnostics and medicines in Malaysia, but also more widely for the Southeast Asia region and Islamic Development Bank countries. And there is also a very big focus on digital health. So we are fortunate that 3 out of 5 key sectors under the Malaysian new Industrial Master Plan does focus on the need to ensure more equitable access to medicines and therapeutics and diagnostics. So in 2025, we set up the International Affordable Diagnostics and Therapeutics Alliance. It has 3 main pillars, but for today, I'll just be focusing on the first 2. But overall, it is about point-of-care affordable diagnostics for cancer and infectious diseases, drug repurposing for cancer, and then we have a more longer-term plan called a plant molecular farming project, which basically will look at how we can develop monoclonal antibodies for cancer therapy more affordably, but that is a longer-term aspiration. So focusing on the need for affordable point-of-care diagnostics, I'm not going to go into deep detail for the purpose of this webinar, but I'm very happy for colleagues to reach out after this webinar and we can chat in more detail. And we would be very happy as well to support with capacity building and sharing in terms of protocol sharing, ideas, knowledge exchange, etc. But our focus really is how we can actually improve early cancer detection and also cancer prevention through point-of-care diagnostics. So we're working on a few mobile point-of-care devices for cancer screening. And one of the devices is for human papilloma virus screening for cervical screening as part of cervical cancer prevention. And this is basically a point-of-care device that weighs about 9 kilos and it fits into a backpack and it's suitable to take for outreach in areas that I've mentioned just now, like in Sabah and Sarawak, that are very far away from a local hospital. And with that, we're also building a pathway to do what we call see and treat. So when the woman comes forward to basically do a HPV DNA test, which is a self-sample now, so women can actually take their own sample without the need for a healthcare worker-assisted sample, and it's highly accurate. And a woman only needs to screen twice in their lifetime in order to pick up the majority of cervical cancers. So that's actually pretty revolutionary. And in our ASEAN and Muslim population, that's actually also seen as very attractive form of screening. So we can actually screen and test at point of care. And from there, we can then actually use what we call mobile colposcopy, which is a camera test to look at the cervix to see if there are actually any abnormalities at the cervix. And if there are precancerous changes, then this can also be treated with thermal coagulation. And this is one of the longhouses that we were at in Sarawak, where we did our cancer outreach screening, where we've also been building community champions, because what we found is that it's very important to ensure that we also build a core set of community champions that are going to help us to highlight this program, to get more women involved, and to basically make the screening and the treatment a success. The second pillar that we've been working on as well is for drug repurposing for cancer. And we basically have gone for the drug repurposing route because we see this as a low-hanging fruit, as we are working with drugs that already have a proven safety profile. And also, in most cases, these are actually generic drugs, meaning that they are actually off patent and relatively affordable. And we've been working very closely with Remedy for All, which is the drug repurposing platform for Europe that was set up in 2022. And we're building a sister project, if you like, with Remedy for All, where we can also work with their digital academy and their resources to help to train our researchers in Malaysia and ASEAN on drug repurposing. And altogether, there are more than 300 generic drugs that potentially have an anti-cancer effect. But the majority of these drugs haven't been taken forward into phase 2 or 3 clinical trials. So more work needs to be done in this space. And so in Malaysia, we have an exemplar project that we set up last year. And this basically goes all the way from policy development, bioinformatics and network pharmacology, through to mechanism of action studies. So we basically also have got mechanism of action scientific work going on for colorectal cancer, cervical cancer, and nasopharyngeal cancer, through to clinical trials. So we've also set up 2 clinical trials in Malaysia at phase 2 level. One looking at artesunate for the treatment of HPV positive precancerous lesions for pre-cervical cancer, and another phase 2 study for colorectal cancer. And alongside this, we're also establishing a funders network for repurposing, because we see that there's opportunities for supporting drug repurposing through investigator-led studies that require a different sort of financing mechanism to traditional pharmaceutical drug development. So this is the Drug Repurposing Policy Roundtable that we convened in Malaysia in October last year. And this brought together officials from the Ministry of Health Malaysia, as well as Ministry of Higher Education, patient advocacy groups working in the cancer advocacy space, academics from various universities in Malaysia, including University Malaya, as well as industry. So we had our local generic drug manufacturers come to this roundtable as well. And there were some very exciting and important networking collaborations that came about as a part of this roundtable. And as I mentioned, we also have 2 clinical trials that are focused around an anti-malarial called artesunate, which comes from a Chinese traditional medicine that's been used for about 2,000 years in China. And it's from a herb called sweet wormwood, or Artemisia annua. And it's got a very good safety profile, having been used to treat hundreds of millions of patients across the world for malaria. But now we are looking to see how this might work for cancer. And of course, understanding the mechanism of action and linking it back to biological plausibility is very important. And this is a big part of our work. And I'm very happy to talk about this more in detail of anyone who is interested. And these are the 2 clinical trials that we're basically running through our Ministry of Health hospitals, as well as University Malaya in Malaysia. And they're currently recruiting, and we're hoping to have some results, at least from our study for pre-cervical cancer by the end of the year. And so I think just to summarize, basically we believe very much that in order to make cancer care more equitable and to basically develop the solutions that we need locally, we need to basically focus on the research being done in the endemic countries, in the global south, and also developing the solutions for the diagnostics and for the drug manufacturing locally, because the global south does have capacity, and the global south actually has the majority of the world's cancer patients that need access to these treatments. And on World Cancer Day, I just want to close by leaving you with a message that comes from one of the great thinkers of global health, Dr. Paul Farmer from Partners in Health, that injustice does have a cure. And for cancer, part of that cure lies in building an equitable research ecosystem in the global south. And I'm very excited because I see that all of us coming together today through the effort of TGHN is one step towards finding an injustice, finding a cure for that injustice. So I look very much forward to the ensuing discussions after this. Thank you.
Thank you very much, Yolanda, for amazing work, very inspirational, and to see that transition and impact on the ground. I'm sure many questions will be coming afterwards from the participants in the Q&A session. And I remind everybody, please use the Q&A option to put down your questions. For our next speaker, it's my pleasure to introduce Professor Nosra Bolatito Afolabi Balogun, molecular biology and genetic diversity research laboratory, and she is based in the biochemistry unit, Fountain University, Osogbo, Nigeria, and she will be talking to us about translating molecular and imaging innovations into equitable clinical impact. So, Nusra, up to you if you can share your slides, please.
So thank you all for joining. I am Nusra, as introduced. So today I would be taking us through, or we would be exploring together how to translate how to translate molecular and imaging advances into real equitable clinical impact in low-income countries. So at the end of the day, I hope to show us how I think we can improve, or how we can improve in training, implementation, quality system, and make the right choices in advancing cancer treatments in low-income countries. So this is our current status. Currently, we have a situation where a lot is happening within the African continent on generally the low and mid-income countries. However, the outputs or the impacts still remain uneven. And this is a classical example of what you see in advanced laboratory, where intensity and cancer diagnosis is impacting clinical decision. Taking a look at the global 2000 on map, we can see that we have intense cancer burden in advanced country. Specifically looking at my country or Africa, we'll see regions where there are very low burden of cancer. However, looking at the mortality rates, we have the mortality in low-income countries is more when compared to the advanced countries. Basically, the reason for this is nothing other than late presentation. We have very few cases, and by the time they are presenting at a time little or nothing can be done to help the situation. Thus, we are looking at a translational pathway from sample to impact. So, because most of my work is in cervical cancer, I'm looking at an illustration where you have the HPV virus infecting a normal cell. The time it takes between normal cell and infection takes on the average of 10 to 15 years. However, in low-income country, there is little or no, at this time, there is little or no diagnosis. However, even when this is diagnosed, a lot of attention is paid into conventional diagnoses like cytology, pathology. However, recent advances in high-income country has shown that the microtumor environment of the cancer plays significant role in the progression of the cancer. For instance, within the microtumor environment, we have the T cells, we have the macrophages, all of which affect or impacts how this tumor transfuse into or how the tumor behave, both with drug or the progression. We currently in my lab and some part of the country have started involving immunohistochemistry so that we are able to look at immunotherapy and other options, and specifically ability to be able to look at the spatial heat map. However, despite this, the major challenge still remains that even when these are done, interpretation remains a major challenge. The conventional diagnostic pathway or diagnostic activity that we have in low-income countries center around the diagnosing of the E6 and E7 oncogene, which we know theoretically or from tumor biology influence or reduce the P53 and RB genes, which are usually involved in cellular transformation. And one of the things we have been able to do in our laboratory is, as against the conventional PCR and the cytology that is being done, we designed a rather quick method of detection, which is based on LAMP. This is a colorimetric detection method that allows the detection of the virulent HPV strands, after which this can be subjected to sequencing, and then we are able to type the virus immediately. Also, we have also tried to look deeply into the microtumor environment using advanced technology. And as mentioned earlier, one of the challenge of our most low-income country, especially Nigeria, is interpreting or effectively implementing this protocol. So the translational gap I have been able to gather from the environment is, yes, we have great discovery. The rate of discovery investigation is on top notch. However, validating this remains a major gap. And because we are not able to validate, implementing what we have found remains another challenge. Translating this into implementable or eventually ensuring it gets to the patients now becomes a problem. And basically, what has been responsible for this is high cost of material, inability to get good skilled personnel. So what I'm saying invariably is, even though some of these facilities are in place, getting the consumables, materials remain a challenge. And when these are available, we also have the challenges in terms of skill, ability to use MRI, ability to use confocal microscope, ability to use any of these advanced diagnostic material. Hence, this tends to prolong the time for diagnosis and eventually times for treatment, which eventually leads to the high mortality as shown earlier. Another factor that has really impacted in low-income country is weak infrastructure. It is a known factor that electricity is a major problem in developing country. So bridging this is one of the things a number of researchers and hospitals are doing, and the challenges of logistic transportation between one laboratory to the other, from the hospital to the point of. Thus, we are proposing that there should be strategic imaging facilities where advanced technology or advanced diagnosis can be done. We should also have targeted molecular assay so that the attention in our region, as currently seen, is where we have histology and limited marker diagnosis. However, there should be shared networking and improving on network such that there is a connection between a number of laboratories, such that we have advanced technologies in regions that is connected to other laboratory that can help when the need for advanced imaging or advanced technology arise. And looking at what we have done, as I mentioned earlier, we only have, most of our treatments is centered around marker detection, maybe looking at the oncological DNA, looking at the P16 histological treatment. Then most of the treatment, as also mentioned earlier, rely on ablation or chemotherapy. The ability to progress into immunotherapy is still very limited. Thus, if we are able to look at a situation where researchers, clinicians, and funders can come together in collaboration such that we can have improved training in most of the facilities, either presently available or the ones that will later be developed. It will ensure that there is stability, sustainability, and equity in cancer diagnosis and treatment. So this is basically what I have, and our laboratory some of the facilities that we have can be seen in the links, and thank you for having me.
Thank you very much, Dr. Balogun, and for amazing presentation. And it is it's always a very interesting thing, like how we think about innovation and advances in diagnostics, therapeutics, and how much in low middle income countries that needs to go in parallel to empowering the infrastructure. And we hope that this platform would be one of the platforms to help bridge that gap and support that development. And I remind everybody with the survey that will help us shed a light on the needs and the next steps. So for the next presentation, and I'm very pleased to introduce Mark Lodge, who is the head of the UK and Ireland Global Cancer Network.
Well, good morning, good afternoon, and good evening, everyone. I'm grateful for this opportunity to talk about the UK Global Cancer Network a little bit, but also about networks and global collaboration and our collective future. Can we have the next slide, please? So to understand our network, the UK and Ireland Global Cancer Network, you have to know its origin story. The network was launched at London Global Cancer Week in November 2020, after a number of well-attended one-day meetings, online and hybrid meetings at the Royal Society of Medicine on the theme of cancer in developing countries. Next slide, please. From the outset, the network's membership was designed to be international, multidisciplinary, inclusive, and diverse, and this is reflected in our steering group. We were very fortunate that Professor Richard Cowan, who was then director of the Christie School of Oncology in Manchester, agreed to take first turn as our chair. The network's scope covers all areas of cancer control and the cancer experience, including people living with cancer, and with a special focus on populations in limited resource settings. The network's mission is threefold: to be a liaison point for all the UK and Irish cancer healthcare professionals and researchers who have an interest in working collaboratively with partners in low and middle income countries. Secondly, to be an advocate for greater investment and engagement with global partners. And thirdly, as a catalyst for new and sustainable projects that improve cancer care delivered to populations in resource-poor settings. And next slide, please. At the time of our launch, Lancet Oncology was planning a series of articles on the role of networks in the development of what was called then the global cancer community. And we contributed a paper outlining the network, which was published in TLO. Alongside a similar paper from the Canadian Global Oncology Network, which had already started. I'll mention them later. We set up a network website, and we got ourselves a logo, and then we began our first project, which was conducting a UK mapping exercise to see how big and how active our community actually was. Can I have the next slide, please? We had some funding, and we're very grateful to King's College London for providing that. We began by approaching the people and institutions we already knew. Next slide, please. These approaches were augmented by a literature search going back 5 years, looking for UK authors of relevant papers. We weren't looking at Ireland at this time, plus anybody who'd already approached us through the network's website. Next slide, please. We sent out invitations to 553 individuals, and we received 88 responses, which is about 16%. Next slide, please. The majority came from England, not surprisingly, but also there was a healthy grouping from Northern Ireland, Scotland, Wales, and from a scattering of different countries around the world. Next slide, please. When we mapped it out, it looked pretty good, to be honest. That this is the map of the UK's activity, the partnership activity we identified, showing the links with partners worldwide. And analysing this collected data, we looked at where people were most interested in working, and we found that there was a large group interested in Nepal. So we contacted these responders and asked them to talk to their partners in Nepal and to find out if they had any needs that our new network might be able to meet. I should apologise. The example I'm going to give you is clinical practice, but actually it has the same patterns that you'd find in if it was research. The research initiative. The response we got from the Nepalese partners was clear. There were 8 radiotherapy centres in Nepal, and the health staff there had been trained in treating adults with radiotherapy, but not children. And as you may be aware, there's quite a difference between the adult and paediatric cancers and how they're treated with radiotherapy. So our UK and Irish members began working closely with partners in Nepal on designing a fellowship training program that would meet that need. Because it's clinical practice, I'm not going to go into that any great details. The Nepal project went live in 2023. Can we have the next slide, please? With Dr. Aileen Flavin, who's consultant radiation oncologist at St. Luke's Radiation Oncology Network in Dublin as its PI, and with part funding from Climbers Against Cancer, who are a lovely group. You can read a full description of the training program in the annual publication Cancer Control 2023, and I will be putting these references in the chat. Also published in 2024 were the results of the mapping exercise, and they were published in Clinical Oncology. Also, I'll put those in the chat. As we grew, we formed closer links with the Canadian Global Oncology Network and with London Global Cancer Week. And most recently, we've been discussing with Adam and Mo about how our network members our research members can actively contribute to and participate in their important and more extensive survey. Next slide, please. So, ending this part of the presentation, in conclusion, the network is functioning on all 3 mission areas. We welcome new members, and we value the work that can be done in collaboration with other actors, in particular with the Global Health Network. As I have a little time left, I'd like to say a few words about the road that lies ahead of us, as it's probable that much of 2026 is going to be spent addressing the challenges that arose in 2025. Can I have the next slide, please? Like it or not, we've come to the end of an era which lasted from the end of the Second World War to 2025, and which created a world that was by no means perfect. There was rank inequality. A minuscule minority of people and countries had far more than anyone else, and too many people and countries had nothing at all or very little. In every country, there were significant sections of the population that felt either forgotten or oppressed. And also there was the catastrophic mismanagement of the Earth's resources and environment, which has led to man-made climate change. But on the plus side, at least there were rules and regulations. Out of the ashes of war, intergovernmental institutions were established based on agreements and consensus. In trade, contracts were signed and generally abided by. Development aid, global funding were features of international relations. Conflicts were averted through mediation, and people could mostly be held to account for their actions. Next slide, please. This whole situation has been ruptured. Here's a picture of some of the people who are responsible for the present predicament, and here's some of the insignias of organizations that have been damaged in the process. Next slide, please. This is what Mark Carney, in his recent speech at the World Economic Forum in Davos, referred to as the new geopolitics, where there are no limits, no constraints, and we have to be honest about where we are. Next slide, please. So this is what the new order is going to look like going forward. National governments and international Government and intergovernmental organizations are still there, but they're a pale shadow of their former selves in terms of providing international health assistance, almost ghosts. And if we are forming or continuing to form networks and have initiatives, then we're going to have to collaborate with partners that perhaps we haven't met before or with whom we've not yet had productive engagement. Next slide, please. Back to Mark Carney. The Prime Minister of Canada was chiefly addressing his remarks to his peer group, the leaders of other middle countries, but they apply to our sector also. Nostalgia is not a strategy. And rather than spending time mourning the wreckage of the old order, we should organise and mobilise, build up our strength at home and act together in collaboration. Next slide, please. Lastly, we should remind ourselves exactly why we build networks, why they're built. And the answer is because we find they're needed. They're often the missing piece in the jigsaw puzzle. In many cases, they begin as ground floor responses by individuals who see that existing initiatives are either insufficient to meet known needs or cannot help them achieve their own objectives. The logical answer is to combine with others to achieve your goals. And in healthcare, more often than not, that means collaborating with global partners, because even in the narrow confines of national health priorities, you'll find that your patient load may be drawn from many parts of the world. Also, no matter how great you've made your country, no one nation or system has all the answers. The true solution to the question, what is the best treatment for patient X, or what's the most effective public health strategy for community Y, may lie many thousands of miles away from you. So global collaboration is necessary, and this means listening and understanding, personally switching from transmit to receive, comprehending the settings in which your global partners live and work, and through building equitable relationships, doing our own part in reducing the global burden of inequality. It's a slow process, but hopefully a rising sea will raise all ships. Next slide, please. I'd like to thank the organisers of this really interesting webinar for inviting me to speak, and I'll be happy to take any questions. Building and maintaining networks takes continuous effort, and collaborating can sometimes be challenging, but we should bear in mind Margaret Mead's words about the importance of the small group of thoughtful, committed citizens, and I stress the word citizens, and also Sam Beckett's perceptive assessment of the latent power of good works. What we build together is going to be stronger than any opposition that we might have to face. Thank you very much.
Thank you very much, Mark. And we keep it in time for the Q&A sessions. So I'm also handing to Farah, if you want to come in, please. And if all the panel can open up videos and speakers, please.
Thank you, Mohammad, and good afternoon, everyone, and welcome to this panel discussion and question and answer sessions on bridging the cancer care gap, connect and collaborate. I'm Farah, and I'm a physician and clinical research administrator based in Lahore, Pakistan, and I'm delighted to be joined by such an esteemed group of experts today from across the globe. And first, I would like to thank the speakers for sharing their insights today, and also the attendees for being with us today. So this is a critical moment to reflect on how we can translate innovation, research, and collaboration into tangible improvements in cancer care, especially in low and middle income countries. For the discussion, we would be taking some targeted questions, and we can see some questions in the Q&A session, and we received some questions at the time of registration. So, without wasting any further time, I would begin my first question. And I've actually combined the questions which are coming in the Q&A and the questions which we received at the time of registration. And I would like to pose my first question to Professor Trudie Lang, and it would be great if Mark can also share his thoughts on the same question. So the question that we have received is, how do you spur on colleagues, peers into local collaborations, research engagements in settings of limited research capacity and funding? And I'm slightly, and a similar question on the same note is, how can institutions in high-income countries shift from a supporting role to a genuinely shared leadership model with partners in low middle income countries? So I would like to have your thoughts. Trudie, would you like to go first?
Yeah, thanks very much. So I'm just going to answer this with what we've learned in practice over the years of trying to enable this knowledge shifting. And I think it's around opening the mechanisms for knowledge to move and about treating everybody as equal partners. So if we often talk about if you have a researcher in Nepal or Peru, the ideal would be that they've got the same opportunities and access to information as a researcher in Oxford or Harvard. And what we need to not do is create that situation where the Oxford and Harvard people have an advantage, or it's a sort of one-way street. And so what we have achieved over the years with the Global Health Network, really through critical mass of having enough members, is that the way that information is moving is south-south, or between Brazil, say, and Angola, and between a nurse in Senegal and a nurse in Malawi. And so the ability to make these changes is really opening up that convening and connecting, and for people to share what works. And so that changes the paradigm about the sort of leading to the second point in your question about how can we change the role of researchers in the global north and in wealthier settings, what the relationship is with our colleagues in the global south. And I think that's really fundamental and very important. And I think it's about equity and opportunities and removing barriers. So there's no payment, there's no barred access. And it's not easy. And as Mark said, it's really hard keeping these networks going, and they do need funding. And that's really hard at the moment too, because keeping this information flow isn't passive, it's active. And then that's, so if you can use the funds to create literally the technical abilities to move information from one place to another and run these activities like research clubs and these processes, and that's and then the critical mass makes it work. So I'll stop there and pass to Mark.
Yeah, thank you. I agree with what Trudie. I'm going to be saying that a lot. I agree with what Trudie says, but just want to make the point. So I just mentioned, I gave a very brief mention of the training program in pediatric radiotherapy that we are doing, and that involves part of it's a 4-step program, but part of it involves fellowships, and the fellowships that we've got from people in Nepal aren't with people in Oxford or Dublin. They're with. And I checked this morning. It was actually the fellows are going to Pakistan. They're going to Bangkok, and they'll probably be going to Tata Memorial in Mumbai. So there's. We certainly wouldn't, as a network, we would want joint. Although we have a named PI. On this thing, we'd actually want joint partnerships. I don't know many people. I don't know many reputable funding agencies who, if you are having a program involves either research or clinical practice training, involving partners from low middle income countries, wouldn't demand that they actually had equal billing. I mean, I think that's where we are now, which is good. And if we're not, and in cases when we're not there, then they certainly should be, because it's just that the other model just doesn't work. It's one of those, whether it's morally right or wrong, and it's probably wrong, it doesn't work anyway. So you do need the equity there right from the get-go.
Thank you so much, Trudie, and thank you, Mark. So yes, the Global Health Network, the Global Health Network, they already have like 1 million registered participants, and that's an example of how the network has been able to connect healthcare practitioners across the globe. And thank you, Mark, for saying, and I was making a note from your presentation as well, that knowledge shared is knowledge gained. And thank you for mentioning the fellowship program and the diverse representation from across the globe, and that's interesting, and that's very good to know. Thank you for sharing those details. I would be taking one question, which is for Nusra, and this is coming from one of the participants. I'm not sure if I can pronounce the name rightly. It is Gidi Abib, and the question for Nusra is, how does combining molecular markers with imaging tools like multiplex immunofluorescence improve early diagnosis or triage compared to using one method alone? And second part of the question is, what are the main challenges for implementing this combined approach in real-world clinical settings, especially in low-resource countries, cost, infrastructure, training, and accessibility? And I am taking a note, Nusra, that you have already mentioned all these challenges, that how these affect working in low resource settings, and some pathways you have already suggested to overcome these challenges. So looking forward. So it would be great if you can share your thoughts on this. Nusra, would you unmute yourself?
Sorry.
Thank you.
Okay. So
Nusra, you're again on mute.
okay, sorry. So combining molecular and imaging techniques in diagnosis in low-income country does two things for us. One, in the first instance, the imaging helps us in typing or understanding these microtumor environments. It helps in identification and characterization of the biomarkers, thereby leading us directly or properly into the type of cancer and most likely the therapeutic approach, especially when it comes to immunotherapy. So we are able to have a better understanding using imaging. However, what molecular does for us is it helps in subtyping. Now, the challenges we have here is interpretation. As shown during my presentation, my laboratory had include immunochemistry, imaging, and scanning. That's microtumor evaluation into cancer diagnosis and tissue classification. However, one of the challenge we have is interpretation, to be able to classically understand the spatial differences between one tumor type and another, and also to be able to advance this observation into clinical impact. So there is some form of this, I'll call it disorganization, not harmonized. So we are not able to, and that was what brought about my last slide on callouts. There is need for synergy. A situation where the clinician, the scientists, and the funders come together in countries, establishing a kind of network that works, where research findings is able to get to the clinicians and under a funded projects.
Thank you so much, Nusra, for elaborating. And thank you so much for showing us the pathway that you propose as imaging hub. That was very interesting concept. Thank you for sharing that. And we have a question for Yolanda. And Yolanda, I'm reading the question from the Q&A. Regarding cancer research equity, how researchers from low middle income countries and East Africa considering the public and clinical research colonization with very low digital health? So this is the first question that I've read for you, Yolanda, and then there are a few others for you and few wishes to, collaborate with you as well. So would you like to speak about with the limited digital health and what are your thoughts about clinical research colonization? Over to you.
No, thank you so much for that question. So I think that's exactly why we actually need forums like what we're having today with the Global Health Network. And it's so encouraging and wonderful to see so many researchers from Africa, from Southeast Asia, etc. Because in order to really move forward on equitable access to cancer treatment and diagnosis, I believe we really need to generate the evidence in the communities that are experiencing the cancer issues. And we need to also look at tailoring the solutions locally. But beyond that, we need to also push. I like what Mark said about the global movement, particularly when it comes to advocating for investment in local cancer care, but also manufacturing of drugs, manufacturing of diagnostics, etc. So why should the world's pharmaceutical companies that focus on drug development all be focusing only on the global north? Why is the global south referred to as the rest of the world, where only 5% of clinical trials for cancer drugs are actually taking place? So this is where I think we really need to come together to build better capacity together. But I think it all starts with a strong research foundation. So what's happened in Malaysia, for example, is that over the last 10 years, the clinical trial ecosystem has really been built up. And we've been empowering research coordinators, nurses, etc., not just doctors, to really get involved in research. And then building those pipelines where you connect scientists and academics in the university setting together with the Ministry of Health hospitals on the ground where the bulk of the patients are presenting is very powerful, because then you create an ecosystem where you can go all the way from basic bench side to bedside when it comes to your implementation science. So yeah, I think continuing that conversation, encouraging each other, and also having this open knowledge exchange. I think that's something we're very passionate about. And in Malaysia in May, we do have our Clinical Research Malaysia Trial Connect conference. It's a big conference, and last year we had more than 1,000 delegates come from all over Southeast Asia. We'd love to see more representation from colleagues in Africa and also East Asia. So we hope to welcome more delegates to that as well. And I think that would be a great opportunity for us to discuss more on our research ideas and how we make some of these initiatives international, multinational through reverse linkage. Sorry, I can't hear you.
So just unmuted myself. So there is a few expressions of connection with you, Yolanda. And in addition to that, there is a question for you that is, does your point of care screening studies for cervical cancer show significant variations of outcomes with the methods or tools of self-collection?
No, so actually there's been very good evidence that now shows self-sampling for HPV DNA testing is actually equivalent to a healthcare worker acquired sample, so very good concordance rates. And what we found actually in our local population in Asia and also in Malaysia, particularly and amongst the Muslim population, self-sampling is actually very acceptable. And this is something that was rolled out in 2018, where there was a policy shift to move away from pap smears or healthcare worker-acquired sampling to self-sampling for low vaginal sampling. And that actually doubled the engagement rate from our local community women. The second part of it, I think that's very important as well, is community champions. So we need to empower our patient advocacy groups and our community women to get involved in the cancer screening program together with us. Because if I myself as a doctor go in there with other doctors and try to speak to the local ethnic indigenous women, for example, about self-sampling, we may still not get them to engage. But if we actually have other local community champion women that we train to become communicators of this program, and then we have women empowering other women, we see that the uptake rate and the acceptability is much higher. And also what's interesting is that now we're also building a reverse linkage opportunity where the evidence that's being generated in Malaysia may also help to inform policy in South London in the UK, because we have a big migrant Muslim population who, again, do not engage in cervical cancer screening. And so we're looking to also design a pilot program looking at self-sampling in that community as part of an ongoing piece of work at City St. George's. So I think there's a lot that we can learn together as a community. And it's obviously not just about the Global North teaching the Global South how to do things. It's also looking at opportunities where we can learn from projects and programs that work well in those communities, and how we could also implement that in the NHS in a now very diverse London population or UK population as well.
Thank you, Yolanda. And I can see there are a few questions about how like researchers and healthcare practitioners can connect and collaborate, and what are the links and pathways. I'll try to answer those, and Adam can also take a lead and answer those questions in the chat or in the Q&A session. And I would like to ask...
I've got a question to Trudie. Is it okay if I...
Yes, please do.
Just using my position here to have a bit of a privilege. Sorry. So just again, I think I really like the point Mark mentioned, and so are you, Farah, regarding sharing knowledge, because knowledge shared is knowledge gained. But also, I think in a general sensitivity, sometimes knowledge is power and data is power. And there might be a bit of sensitivity in the South of sharing information and data, and whether there might be any measures to protect these data. And so what do you think, Trudie?
Great. So I think there's two sides to this. There's movement of knowledge and know-how, and then there's actual research data. So I'll just take those separately. And I know there was a question earlier in the chat about the survey data as well, we've done on competencies, and also that reflects on the survey we're going to asking people to take part on this. So that first, when we do a survey or any of the interactions or relationships that the Global Health Network has with its membership, it's completely confidential and is covered by all the data protection rules. So if we ask you to fill in a questionnaire, we have your email address, none of that is shared, and you can fill in the surveys anonymously. Then for people sharing information on the Global Health Network, and that is people who are a member share things like their protocol templates or their community engagement process. They might write up an article on how they did research, but they're not sharing their actual research data. And so when people share this is how I approach my research. And if you look on the Global Health Network, you can see so many examples of people just explaining their stories, little videos, or sharing protocols or data template forms, but they're not sharing their actual research outputs. They're sharing the knowledge on how they did research. And so for that, they do usually disclose who they are, because they're happy and proud to be sharing what works well. And that's the usual community of practice way it works. But you can also engage completely confidentially when we do things like the surveys, which this survey will be. And so the last point around actual research data and sharing research data, that's really fundamental. And I touched on that far too quickly in my talk, but it's a huge focus for us. And this is my sort of real passion at the moment to champion data sovereignty, and that there's often this complete confusion about the term data sharing, because papers and funders and publishers encourage people to share data, that your research data, so others can do secondary analysis. And that's great, and it's really important, and it's how the world progresses. But a lot of collaborative research is around one person extracting all the data and doing the analysis in one place. And that's often some of the inequity around health research. So one of the things we're really encouraging is that data stays where it's gathered and it doesn't need to move. And you can do federated analysis and all sorts of ways to get around that, to protect data. There's a lot more written about this on the Global Health Network and more to come, but just really clearly to differentiate between sharing knowledge and sharing your actual research findings, which of course you should be able to keep and hold on to, and is very important to keep the confidentiality of that data and the ownership and the recognition for it. So 3 complicated areas I hope I've made a small attempt to cover. Thank you.
Thank you very much. You definitely did.
All right. So one question, and I would like to hear from all of the speakers today on this, that how do you, with the launch of this Global Cancer Hub, how do you see meaningful engagement and success would look like following this launch and following today's discussion? So maybe we can start with Mark, and then we can go to Nusra and Yolanda, and then Trudie. Mark, would you like to chime in that how you see the next?
I think at the very first thing we will do, we are doing, in fact, is telling our network about this. Okay, because I think we want this is the confidentiality of sharing members' information and so on. We want all our members who have an interest, specifically our research members, to come and be part of the hub and be part of the survey and so on. And we, I think, have to talk more. I'll be talking more with Adam and Mo about actually how can be more useful than that. But that's our first step, if you like. Now, other people might have their ideas, might be more further developed than that. But our first step is to get our people to say this is a good enterprise. You should have, should contribute to this. Can I just also say just something about, we've been talking about data. Of course, data is different from information, of course. But there's one thing. I was working some years ago with a group called the Network of African medical librarians, and they were looking at a project where you go to a university and you get all down their PhDs thesis related to your particular subject and make it available online. And that was a great struggle, but there was quite clearly the stuff that was coming out of universities or the research was almost inaccessible in some parts unless it had been written up in a Western journal. And this is an example of looking at a problem and saying, what's missing? What's the bit missing that we can do? Now, the hub is one of the bits that has been missing. It's going to be terrific, but there are other bits as well. We need to be making whittling our own jigsaw pieces and fitting them in when we come to that, because clearly what we've had in the past hasn't worked, or only worked to the advantage of a few. That's what I'm saying. So the answer is about that for the hub. Then we'll be bringing our people to you, and then we'll work more about developing more positive and constructive ways of engaging.
Yolanda, can we have your thoughts on this?
Thank you. So I think we're hoping that we'll be able to set up a Malaysian chapter soon of TGHN, and we're hoping to use that as a leverage for an ASEAN hub, basically, because 2025 Malaysia was the chair of ASEAN. There was a lot of positive activity around that as a result of different ministries of health within ASEAN coming together, different researchers coming together. And obviously, we'd like to highlight TGHN Oncology Hub at the Clinical Research Malaysia Trial Connect event in May as well. And then I hope that from this, we'll see a lot of organic relationships and networking arise, which hopefully trials where we can see more repurposing studies that are not just being done in Malaysia, but potentially also being rolling out across the TGHN network. And similarly, with some of the solutions or the learning that we've developed from the point of testing for cervical cancer screening, to see that also be taken up in other places through reverse linkage, I think would be the sort of impact that we would be hoping for through the TGHN Oncology Hub.
Thank you, Yolanda. And before we close, can we have like a very brief comment from Nusra? And then probably we'll be closing.
Thank you very much. So, from my side, we look forward to a more synergetic networking within the continent and TGN at large. We're looking at a situation where the collaboration between researchers, clinicians, and funders can be strengthening through TGN, and at the same time, a situation where molecular imaging, molecular biology, and imaging could be used impactfully in our society. Because I believe that will improve diagnosis, is going to improve treatment as well.
Right.
So, and
Thank you.
Yeah.
Thank you so much, Nusra, and all the speakers. And today's discussion has highlighted that bridging the cancer care gap regarding not just innovation, it's about equity collaborations. And because we have used our time, so this is the time to close. I'm taking this opportunity to thank all the speakers, all the wonderful attendees. Thank you so much. And before this, you were able to see the survey. It would be great if you take time to complete this survey. As Adam has told, that you can flexibly complete the survey at your convenience. And with this, I would be closing today's webinar and extending thank you from the entire team of the Global Health Network and all the speakers. Thank you so much. Thank you.
Thank you.
Bye-bye.